Before a human is born, the placenta acts as the primary excretory organ. It filters waste and regulates fluids, meaning the fetal kidneys are essentially offline and not required for systemic homeostasis. The moment the umbilical cord is cut, that safety net disappears. The newborn's kidneys must instantly wake up and take total control over fluid, electrolyte, and acid-base regulation. This creates the central paradox of neonatal nephrology. Anatomically, the kidneys finish building their physical structures around 35 weeks of gestation, but physiologically, their actual ability to filter and process fluids severely lags behind. This line chart tracks the glomerular filtration rate, or GFR. During gestation, fetal GFR remains almost completely flat, near zero. At birth, it must spike violently upward to meet the exact physiological demands of life outside the womb. Managing a premature infant in the NICU requires navigating this exact gap. The organ looks complete, but we are asking an immature filtration system to perform a high-stakes job it is not fully ready for. To understand why the neonatal kidney is so fragile, we have to look at how it is built. The process starts at week 4 of gestation, when a layer of cells called the intermediate mesoderm migrates to form the nephrogenic cord. The kidney develops in 3 sequential stages. The first 2 structures, the pronephros and the mesonephros, form and then quickly degrade. They do not process waste, but they leave behind the critical duct architecture that will eventually build both the urinary and genital systems. By week 5, the definitive kidney, the metanephros, begins to form. This requires a precise physical interaction, where an outgrowth called the ureteric bud meets a cluster of cells known as the metanephrogenic blastema, inducing the blastema to form the actual filtration units. By the 3rd trimester, these early kidneys begin producing ultraurine. While not needed for waste removal, this fetal urine becomes the primary source of amniotic fluid. If early embryological development fails and urine output stops, amniotic fluid levels drop rapidly. Without adequate amniotic fluid volume, the fetal lungs are physically compressed in the womb and fail to develop, leading to lethal pulmonary hypoplasia. The functional unit of the completed kidney is the nephron. It manages fluids through a strict sequence of 3 actions: ultrafiltration, reabsorption, and secretion. Let's look closely at where this sequence begins. This diagram details the glomerular apparatus. Blood plasma arrives at this dense vascular knot of capillaries and is pushed outward into the surrounding cavity, called Bowman's capsule. This movement is determined by a strict pressure equation. Hydrostatic pressure, driven by the heart, pushes fluid out of the capillaries. Working against it is oncotic pressure, the osmotic pull from large proteins trying to draw fluid back in. The capillaries are lined by a filtration barrier that blocks large proteins. Because the resulting ultrafiltrate is nearly protein-free, oncotic pressure is close to zero. Filtration is therefore almost entirely dependent on the forward push of hydrostatic arterial pressure. This creates a mechanical requirement that the newborn struggles to meet. Neonates operate with a lower mean arterial pressure, combined with highly constricted renal blood vessels that create significant resistance. Because of this resistance, the newborn kidneys receive only 4 to 6% of the total cardiac output during the first 12 hours of life. For comparison, an adult kidney receives roughly 25%. The system operates at the absolute margins of its physical capacity. Neonatal filtration relies on a precarious, pressure-dependent bottleneck running on minimal cardiac output. Beyond filtration, the newborn kidney also struggles to reabsorb what it filters. Nephron formation starts deep inside the kidney's medullary region and builds outward toward the cortex. As a result, the neonate has a small number of deep, mature juxtamedullary nephrons, but the vast majority are shallow, highly immature superficial cortical nephrons. The primary site for concentrating urine is the ascending loop of Henle. Because it is the final structure to fully form, these superficial nephrons possess very short, underdeveloped loops compared to the mature deep nephrons. This data matrix compares renal function across gestational ages. Look at the fractional excretion of sodium. An infant born before 30 weeks loses nearly double the sodium of a term infant, while their maximum urine osmolality maxes out significantly lower. The premature infant can secrete fluids, but lacks the physical architecture to pull solutes back into the blood. This leaves them uniquely vulnerable to severe sodium wasting, glucose loss, and rapid, dangerous fluid imbalances. To survive these inherent limitations, low filtration rates, and high vascular resistance, the newborn relies heavily on neuroendocrine compensation. This flowchart maps the renin-angiotensin-aldosterone system. When systemic blood pressure drops, the vessel walls of the afferent arterioles stretch less, triggering specialized cells to release the enzyme renin. Renin enters the plasma and catalyzes the production of angiotensin I. As blood circulates, a converting enzyme rapidly transforms it into angiotensin II. Angiotensin II then stimulates the adrenal cortex to secrete aldosterone. This hormone forces the kidneys to aggressively reabsorb sodium and water, expanding the extracellular fluid volume and raising blood pressure. To maintain baseline perfusion, newborns operate with baseline renin levels that are significantly higher than those found in adults. The neonatal circulatory system does not function comfortably at rest. It is forcefully upregulated, working overtime under constant hormonal stimulation just to maintain baseline renal perfusion. When a system requires this much continuous compensation to function, the margin for error is razor thin. Acute renal failure is a frequent and severe threat to premature infants in the NICU. A bout of hypoxia or simple dehydration causes systemic blood pressure to drop, and the delicate pressure gradient in the glomerulus instantly crashes, halting filtration. The kidneys are also vulnerable to the very treatments used to keep the infant alive. This matrix outlines specific nephrotoxic medications like aminoglycosides, indomethacin, and amphotericin B. These drugs can poison the renal tubules and directly cause intrinsic failure. Clinicians must distinguish between these mechanisms. Pre-renal failure occurs when the kidney is normal but lacks the blood perfusion to filter. Intrinsic failure means the physical tissue itself has sustained damage, such as acute tubular necrosis, resulting from prolonged oxygen deprivation or drug toxicity. Because the neonate has virtually no physiological reserve capacity, these insults do not resolve easily. Minor drops in blood flow or brief exposures to toxins rapidly compound, turning temporary stalls into permanent kidney damage. Detecting this damage requires recognizing the cardinal signs of acute kidney injury. While a sudden drop in output, oligoanuric failure, is a clear indicator, up to 30% of cases are non-oliguric, meaning the infant continues to produce normal or even high volumes of urine while the filtration quality fails. Standard bedside tools can also deceive. Urine-specific gravity tests, which measure concentration, are often highly misleading in newborns because their immature loops of Henle already create a severe baseline reabsorption deficit. Evaluating glomerular filtration rate relies heavily on tracking serum creatinine. However, an initial creatinine level taken at birth primarily reflects the mother's clearance, not the infant's. Only by tracking serial creatinine levels over several days can a nurse accurately measure the infant's actual renal function. This demands strict adherence to intake and output tracking, daily weights, and vigilant edema assessment. Overloading an infant who has stopped filtering leads directly to severe hyponatremia and potentially fatal seizures. The neonatal kidney may look completely formed on an ultrasound, but its internal mechanics are balanced on a knife's edge. Precise, proactive bedside monitoring is the only effective defense for an organ operating at the limits of human physiology.